Hello, Indo Canada. Very excited and happy to be here this morning in a virtual version because unfortunately today I am flying, I'm traveling, so I'm not able to be live. I'd like to thank Endo Canada and of course Emma Whelan for inviting me today. I saw the list of speakers, which is amazing. And I really wish I could have given you a live presentation and be able to address and answer questions. Nevertheless, I've prepared a PowerPoint presentation that I'm going to go over now, which I think will help address this issue, which interests many individuals in the world of endometriosis, as well as in the world of reproductive medicine. So I'm hoping you enjoy my presentation today. And I'm looking forward to another opportunity to meet you, either virtually or in person in the near future. Again, thank you. Thank you, Emma, for the invitation, and thank you, Endo Canada. So today's topic that I'm thrilled to talk about is that of immune markers and the person who experiences miscarriages and implantation failure. It's a topic that I feel is very close to me because as a reproductive endocrinologist, as well as an endometriosis expert and a reproductive immunologist, I have seen how these three areas have a tendency to come together with what one may call a perfect storm in some patients, where unfortunately all these conditions come together to create havoc on a person's reproductive system. And I feel that it is an important topic because it's something that has not really been addressed in a long time by doctors, because I feel that most doctors have narrow knowledge in their own specific field, and very few doctors expand beyond their field of knowledge. So you'll have the fertility doctor just focuses on fertility. The reproductive surgeon does maybe an incredible job doing surgery, but then when they have to come together, sometimes it's a problem. And I wear multiple hats, as you guys know, and certainly as a fertility specialist and an immunologist, I see many patients who come to us with either unexplained infertility or recurrent pregnancy loss or recurrent IVF implantation failure. What is interesting is that many of these patients are labeled with a diagnosis of unexplained infertility, unexplained miscarriages, unexplained pregnancy loss. And but it turns out that many of them come to us with when we start looking into their immune system, they come to us with an altered state in their immune system. Many of them have autoimmune disease that some of which are obviously fully conclamated, but some of them are actually in very early preclinical stages. And so by doing immune testing, which we have been performing for about a decade, we have been able to uncover what I feel is some very relevant information for what pertains the role of the immunological system in reproduction, as well as in endometriosis, of course. The first step that I'd like to start talking about is the way we see the embryo. And I always tell the story, which people who know me have heard me repeat the story many times, which is that our ancestors, our amphibian ancestors, 300 million years ago, obviously laid eggs, and they left the eggs on the beach, and then they would go back and find the babies. But sometimes they would go back and there would be no babies because the predators would eat the baby. And the solution for that was obviously what we have now, at least one of the solutions that evolution created, was the fact that, we carry the babies inside of us. And what happens in this case is that the baby is what we call the baby, what's called a semi-allograft. The baby is foreign to the mother because it contains 50% of the DNA of the father. And the maternal immune system normally tolerates the embryo because of immune privilege in the pregnant uterus. But the immune privilege can be disrupted by the presence of inflammatory and autoimmune conditions. And loss of immune privilege leads to rejection of the embryo, the fetus, and cause unexplained infertility, recurrent implantation failure in IVF, recurrent pregnancy loss, and complication in pregnancy, IUGR, preeclampsia, and also as well as post-pregnancy complications. So this is something that we've known for a very long time, but a lot of doctors still have a hard time wrapping their hand around this type of problem. But there are certain things that we do know. That the first one is that evidence that immune disease leads to reproductive failure exists. There are some very well described syndromes like antiphospholipid syndrome, APS, which consists of presence of at least 3 antiphospholipids and presence of rheumatoid factor, and so that's a recognized syndrome that causes pregnancy complications. And but there's also evidence that preclinical, so not yet diagnosed states of autoimmune disease can lead to reproductive failure. And there's plenty of studies that show that women with reproductive problems developed autoimmune disease later in life. And this is also true for women with endometriosis. There's a number of epidemiological studies that show that there is a close connection between the presence of endometriosis and development, for example, of Crohn's disease, ulcerative colitis later in life, about 10 years after the diagnosis of endometriosis, with about a 30-time increased risk. So there is a very close connection between autoimmune diseases and reproductive failure, and also between endometriosis and autoimmune diseases. There's a whole very deep science, but not, I would say, not as much as we would like to have evidence about the immunological aspects of endometriosis. Endometriosis is associated with peritoneal inflammation and also altered cellular and humoral immunity. We have measured elevated levels of inflammatory cytokines and other inflammatory mediators in the peritoneal fluid and in blood. There's also altered levels of functions of macrophages, natural killer cells, NK cells, dendritic cells, and regulatory T cells. There's altered levels of B cell activity and productions of autoantibodies, including anti-nuclear antibodies and anti-endometrial and anti-endovarian antibodies. It's debated, though, whether the inflammation is there because of the endometriosis or if the endometriosis lesions promote inflammation. And it's probably a combination of both. For example, the low natural killer cell activity is probably associated with a lower immune surveillance and allowing these lesions to grow with more ease. So probably less immune surveillance, and then you have of course, the inflammatory component when the endometriosis is full blown. But certainly we do know that there are markers of endometriosis, immunological markers of endometriosis, which are associated with endometriosis, but also associated with infertility. We also know, as I just was alluding earlier, that endometriosis is associated with several autoimmune disorders. The big one is Hashimoto thyroiditis. It is so common in our patients' population and also frequently undiagnosed, but also lupus, antiphospholipid syndrome, scleroderma, Sjögren's syndrome, skin diseases, psoriasis. Autoimmune diseases are associated with various combinations of HLA alleles. And HLA alleles, just so that people understand what they are, they're highly variable amongst individuals, and the combination versions of these genes, alleles, in individuals form what's called a haplotype. That is, it's a fingerprint for disease. Like autoimmune diseases, endometriosis is associated with particular HLA alleles, more specifically the ones that we find in endometriosis, and that also overlap with autoimmunity. The most classic one is haplotype 8.1. We see that so often in our patients with recurrent pregnancy losses of infertility. And it's also associated with lupus and Sjogren's syndrome. We also see the associated with the haplotype DRB81 and other haplotypes. We are not the ones who have coined the term silent endometriosis. It's a term that's been around for a long time, mostly because endometriosis has always been associated with pain and menstrual cramps and systemic pain or bloating and all sorts of like physical symptoms. But many patients with endometriosis demonstrate one symptom that has often been disregarded, and that has been infertility, recurrent pregnancy loss, and recurrent implantation failure. Many of these patients have endometriosis without the presence of the classic clinical symptoms. Also because we know that the classic symptoms also do not correlate often with the extent of endometriosis. Minimal endometriosis can cause extensive pain, and extensive endometriosis can be present without any pain. So one thing I have to say that patients, when actually interviewed properly, ultimately will always display some symptoms, physical symptoms, but if you ask the questions, you get the answer. So I feel that sometimes it's also a misnomer, because if you ask, many patients will say, hey, I've been in pain my whole life, and nobody ever asked the questions. But the clinical indicators of what we have been calling now silent endometriosis are, number one, a family history of endometriosis. The risk is 7 times greater in relatives of affected individuals. There's physiological symptoms, poor egg quality, low ovarian reserve relative to age, reduced uterine ovarian blood flow, increased resistance observed by transvaginal sonography with Doppler flow studies that we perform, endocrine signs with elevated FSH and low AMH, genetic signs, presence of HLA haplotypes that we just talked about earlier, associated with autoimmune diseases, and also immunological, of course, elevated levels of certain cytokines in serum, such as TNF-alpha, interleukin-10, interleukin-18, interleukin-6. And obviously the presence of certain autoimmune conditions, certainly Hashimoto's thyroiditis and antiphospholipid syndrome, or if not antiphospholipid syndromes, elevation of individual antiphospholipids at high levels. This is kind of like the fingerprint of endometriosis that we see in our immune report. And I think that it's very important to observe that many doctors actually do carry out some of these tests, but they don't connect the dots. And I think the problem here is, I think a very important problem is necessity to be able to connect the dots to give people answers. You know, we need to be able to do that. Connect the dots between the immune and endometriosis and fertility miscarriages. Now, when endometriosis is suspected, and of course, as you know, I am an endometriosis surgeon and an excisionist, and many of my colleagues today at the conference will be talking about excision and endometriosis. I saw Dr. Mossbrucker, Dr. Sonervo there, and many others who do a beautiful job both professionally, but also give great lectures and explaining things very, very well. So I don't have to tell you that laparoscopy should be considered when these indicators are present, these immunological indicators, even in women with unexplained reproductive failure, even in absence of classic symptoms. We also do believe, I do believe that in some patients who have a greater risk for immunological risk, this should be also combined with immunotherapy. And that would significantly improve fertility and pregnancy outcome for many patients. So I really feel that a combined approach is useful in some patients. But certainly laparoscopy should be considered as a treatment for unexplained infertility in presence of all these signs, clinical signs and serological signs and ultrasonographical signs that we just mentioned in the earlier considerations. So, like I said, it's a global view. It's a bird's eye view that not all fertility doctors have, and sometimes endometriosis experts know more than fertility doctors in this area. Now, who should have immune testing? And I think this is an important question, because many patients are like, well, how, does everybody have to be immune tested? And my recommendation is that individuals who've had a miscarriage with normal embryos, more specifically, and or multiple miscarriages should consider getting tested immunologically and tested for endometriosis. Patients with failed multiple IVF transfers, especially if with PGT tested embryos, and depending on how many embryos you have, maybe start getting tested earlier. Patients who have a history of infertility and autoimmune conditions like lupus, thyroiditis, psoriasis, and obviously immune testing also recommended for patients who have a history of endometriosis and miscarriages and fertility. So I think that it's a broad group of population, and so but at the same time, I don't think people are willing to accept unexplained. I think that there's been a tremendous amount of tolerance for miscarriages, for example, multiple miscarriages, where people are told that are just caused by bad luck. And perhaps doctors should think of endometriosis faster as a potential cause, and even in absence of symptoms. So I think that's very important. So how do I get tested? And I have to have a disclaimer here, which is I have a conflict of interest. I am a founder of a company that's called Pregmune, www.pregmune.com, which is one of the ways to get tested. But you could also go obviously to your doctor and ask for at least basic immunological testing, or look for a reproductive immunologist. There aren't that many, but they are around if you pay attention. And to get a fuller picture, I think, and a deeper picture, if you want to find answers to pregnancy losses, endometriosis related, or implantation failures, I think it's always good to look for a reproductive immunologist and get an additional opinion. Again, I would like to thank the organizers for this invitation. I'm sorry I couldn't be in person, so I had to record this as I'm flying today, but excited to be here. Again, looking forward to meet you at the next conference, and hopefully at the Endometriosis Summit, which is one of the sponsors of this meeting today, along with my co-founder, Dr. Sally Sorrell. Again, thank you very much, and I'll see you very soon.